Greetings, students. We are now beginning our unit on the cranial nerves, and this morning what we expect to do is to look at cranial nerve 1, then the cranial nerves that manage the visual systems, which is 2, 3, 4, and 6, and we'll introduce you to cranial nerve number 5. So the objectives for the entire session, which will be, by the way, in two different parts, is to review the location and associated structures and functions of cranial nerves 1, 2, 3, 4, and 6. Look at what a lesion in the visual pathway will do and in terms of what visual deficits may follow. And then look at some of the anatomical features of the eye and some of the common dysfunctions that PTs encounter when they're working in the clinical environments. We're going to review the tests of dysfunction for the cranial nerve 1, 2, 3, 4, and 6. And we're going to integrate information to explain gaze stability and coordination of smooth pursuit. And then we're going to identify areas in the central nervous system that are part of the control system for vision. And we'll introduce cranial nerve number 5. A quick note that we are not going to be including cranial nerve number 5 on test number 2, and we'll say more about that later. So let's just take a look at an overview of all of the cranial nerves, and your Lundy-Ekman does a good job of summarizing that. What the cranial nerves do is they supply motor innervation to the muscles of the face, eyes, tongue, and jaw, as well as to two superficial neck muscles. You already knew that, like the sternocleidomastoid and the trapezius. They transmit somatosensory information from the skin, muscles of the face, and the temporal mandibular joint. They transmit special sensory information related to visual, auditory, vestibular, gustatory, olfactory, and visceral sensation. And then they also provide parasympathetic regulation of pupil size, curvature of the lens of the eye, heart rate, blood pressure, breathing, digestion. So it's a lot of different functions. And as we've already said, we're going to be focusing this morning on visual information. As you recall, we have 12 pairs of cranial nerves, and they come from the surface of the brain, and they innervate structures of the head and neck. And then cranial nerve number 10 also innervates thoracic and abdominal viscera. We got into that a little bit when we talked about the autonomic nervous system. And there are two cranial nerves that are entirely contained within the skull, that's 1 and 2, and only myelinated therefore by oligodendroglia. Versus all the other ones will have a myelinization by Schwann cells because they've got processes outside of the skull. So all of the cranial nerves except 1 and 2 have processes outside of the skull that have Schwann cell myelinization, and 1 and 2 are all within the skull and myelinated by oligodendroglia. So some are motor, some are sensory, and some are mixed. Most of the cranial nerves exit from the brainstem. They have their nuclei in the brainstem, and we're going to note exceptions to that as we go along. And therefore, injuries to the cranial nerves and mapping and testing of those are often considered to be diagnostic of where a brainstem is injured following a traumatic event. That's why if you're working in a environment that is working with folks with traumatic brain injury, you will see that cranial nerve testing is something that was done with much precision and much extensive repeating, because the cranial nerve injuries will correlate with the brainstem injuries, and you'll be able to see that on the next slide. Take a look at this slide over here, and you can see that essentially what it looks like is a map of the cranial nerves. You see 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 come off almost in descending order. 1 and 2, where you remember, are those that are completely contained within the skull, and so have a different pathway and different location than what you're seeing here. Just a quick note, you will be responsible for being able to identify all of these cranial nerve exits on the picture that you see on your left here. The cross sections that you have on the right give you another visualization, another image in terms of being able to see where they are, but you will not be required to label that one. The one on the left you would be expected to be able to label. So as we said, each region gives origin to certain cranial nerves. But let's take a look first at the olfactory nerve, cranial nerve number 1. So the cranial nerve number 1 conducts information from the nasal chemoreceptors that are located in the olfactory bulb. And from the bulb, the information travels to the olfactory tract, so it goes from bulb to tract, and then carries information to the primary olfactory cortex and to 2 areas in the medial temporal lobe, the amygdala and the parahippocampal gyrus. So we talked about that when we talked about the limbic system. And we also talked about that next point there, that the amygdala is involved in the emotional response to odors. So it sends information to the hypothalamus, which is responsible for the odors that result in hunger. So smells can generate an emotional response, and we talked about it being well integrated with memory in the parahippocampal gyrus. And we also know that smell can exacerbate hunger, or maybe even initiate hunger. If you weren't hungry before you smelled something, you might become hungry when you smell something that's appealing, that's associated with food. So smell is the only sensory input that reaches the cortex without going through the thalamus, which is kind of an interesting piece of information. So here's a picture of cranial nerve number 1 in terms of how it moves. So you see, it starts with the olfactory bulb there at the very rostral end, and then goes to the tract, then transmits through a couple of different stria to the amygdaloid body, near the amygdaloid body, and synapsing there in the cortex. Remember the testing of cranial nerve number 1 that you talked about in Foundations of Examination. When you test cranial nerve number 1, it should be 1 nares at a time, so you're going to block the other one when you're testing it, and you're going to present the individual with familiar smells. But remember that you don't want the person to visually identify the smell, because the memory of that smell may evoke the sense that the person does smell that particular substance, or at least make them unsure of their responses. So let me just give you an example of this. If you were trying to get them to say smell coffee, you wouldn't present it to them in a recognizable coffee cup where they're going to anticipate the smell of coffee. You would want to put it in a container that's nondescript, where they would not be able to predict what smell they might encounter. So dysfunctions of cranial nerve number 1. One point to be made here is that the sense of smell does decline with increasing age. Replacement of olfactory nerve cells happens every 30 to 90 days, which is quite frequent, but that replacement rate, it declines as the person gets older. And that's probably, since it's connected to taste, also why the sense of taste declines with age, where taste don't seem quite as strong in somebody who's older, an older individual. The inability to smell is called anosmia. That's the inability to detect smells. And traumatic brain injuries that fracture or damage the cribriform plate uh, and therefore shear the olfactory nerve is not an uncommon traumatic mechanism of injury to the cranial nerve number 1. But it's also possible that somebody may have chronic injuries that are incurred by smoking, or maybe somebody's just got like long-term congestion, and that may interfere with the sense of smell in the short term, and over time may incur long-term impairments. So just this is a picture of the cribriform plate. And so an anterior skull fracture, for example, such as might happen if there's somebody goes forward into the windshield, may result in a fracture of the cribriform plate. And one of the signs and symptoms of that is that cerebrospinal fluid may also leak through the nose. And that's one of the things that they look for after a skull injury, with the expectation that that kind of a sign and symptom may be indicative of a fracture of the cribriform plate. So we'll move on now to the visual systems 2, 3, 4, and 6. Remembering that the visual system supplies sight, processing of visual information is included in that, so the recognition and location of objects, control of eye movements, and then the information that it generates is also used to control postural and limb movement. So it's a pretty complicated system, and we're going to spend some time on it. And we're going to start doing that by thinking about the optic nerve and the visual system. In order to do that, it's important that we start by looking at the parts of the eye. So we're going to present a brief overview on the parts of the eye so that you get a broader picture of what how the eye functions in the transmission of the information via the optic nerve. So here you have a diagram of the eye, and I want you to just pay attention to a few areas here. So for example, the macula that you see, that's part of the retina, because the retina is also identified there. The macula is an area of high acuity. The macula allows for very clear distinctions in visual objects that you're looking at. And I just want to point out again that when you look at, and all of that goes to the optic disc, and the optic disc is where the information transmits to the optic nerve. And that diagram is blown up a little bit to your right, so you can see a little bit more in detail how that optic disc goes into the optic nerve. And just a reminder that the CNS is actually responsible here for the myelinization of the optic nerve via the oligodendroglobia. I can say that. And so here's another even more detailed picture of a cross-section of the human eye. And just once again, I want to orient you to the macula, which is where you're going to get an inverted image of the object. And just a reminder in case you're unfamiliar, because of the way that's projected on the retina, you get an inverted image of the object, and it's your central nervous system, your cortex, that flips that image back right side up. But if you follow how that image is projected, it's actually inverted on the back of the retina there. And just so again, you see where the macula is, and you see that that's where the image is going to be most clearly projected. And so the next few slides will talk about some of these features in just a little bit more detail. So the sclera and cornea are the fibrous outermost layer, and they provide the shape to the eye. And the sclera also attaches to the extraocular muscles that we'll talk about with 3, 4, and 6. The cornea is the transparent piece in the very front of the eye, centrally located at the front of the eye, and that light entering the eye is refracted, therefore, by the cornea, and you can see that pretty clearly on that diagram. The iris is the muscle that controls the opening size of the aperture, the pupil, because the pupil is, of course, where the light enters in, but the iris controls just how large that opening size is. And the choroid connective tissue and blood vessels nourish the outer layer of the retina. And the ciliary body, the muscles and processes, control the shape of the lens, because remember, the lens is going to refract the image, and then helps form the aqueous humor as well that is within the eye. The retina has 2 layers, basically as a neural layer with photoreceptors or photoreceptor cells that detect light, and then a pigmented layer which supports the neural layer. And just a quick note about those photoreceptor cells: rods work in low light and cones see color. So the photoreceptor cells consist of rods and cones, and rods work in low light and cones see color. And the way I remember that is that cone starts with a C and so does color. And macula is in the center of the retina, an indentation called the fovea that has a high concentration of light detecting cells, and that's why it is responsible for that high acuity vision that we've already mentioned. The optic disc is where the optic nerve enters the retina, and here's something kind of interesting about that you probably already knew, and that is where the connection is between the disc and the retina. So right on the sides there, where the optic disc and the retina sort of connect, is where we also have a blind spot, because we really have no photoreceptor cells right there, and so we end up with a blind spot that you recognize when you drive. You have to accommodate by head checking, because a whole car can fit into that blind spot otherwise, if you don't visually reorganize where that blind spot is hitting, so that you do see obstacles that previously you missed. So you do have a blind spot where that optic disc and the retina meet. For the most part, your brain fills in that blind spot when it creates an image. But you have to accommodate for it under certain conditions, such as driving. So back to this picture here. You see the whole picture here again. You see how light enters the pupil, and that the ciliary muscle can accommodate the shape of the lens, and that the iris controls the aperture itself, and does so based on the amount of light in the system. The image is projected back to the retina. The macula is the most sensitive part of that, and then it's going to be carried subsequently by the optic nerve to the brain, where sense is going to be made of that picture. And you remember that where the optic disc meets the retina is also a place of no vision, a blind spot. So let's explore some clinical applications related to some of the structures that we just talked about. Probably one of the common ones is glaucoma, and that's a disease of the eye that results in damage to the optic nerve. And that damage occurs because there's an increase in the aqueous humor, most of the time because it's not draining appropriately. So that increase in aqueous humor causes damage to the optic nerve over time, and that can lead to vision loss. And loss of peripheral vision is an early sign. Although visual acuity can also be affected, the peripheral vision is the most likely to be lost early on. It can also result in pain and maybe some redness if you were able to look inside, and also seeing halos around lights. Glaucoma can't be cured, but treatment can help control it. So, for example, surgical techniques to drain fluids, eye drops to lower pressure, medicine to cause the eye to decrease how much fluid is actually produced. So glaucoma is rarely cured, but it can often be controlled, at least to prevent some additional damage from happening. Macula degeneration is another common clinical application of deficits as it relates to the eye itself. And most macular degeneration is age-related, and it can be exacerbated by some lifestyle things like smoking. High blood pressure and high cholesterol can contribute to that. And what occurs in this case is that the individual loses central vision, which you can imagine is pretty deleterious to their ability to manage their environment. They feel like they've got a blurry spot right in the middle of their vision, and that can get darker and bigger over time. There are new treatments available to halt progression, but the treatment will also depend on underlying causes. And one of the treatments that seems to be able to have some helpful impact is vitamin supplements, particularly CE, beta carotene, zinc, copper, increase in omega-3 fatty acids. So they usually tell people with macular degeneration to eat a lot of fatty fish. And the beta carotene increase is not used with smokers, though, just as a caution, because there's a higher incidence of lung cancer with increased beta carotene in when smokers use that. And this is just a visual image of what a macular degeneration might look like to somebody who's experiencing that health condition. So you see that on the picture of the right, the blurriness is right in the central piece of their vision, which can be, as you can imagine, quite debilitating. So clinical applications, again, related to the eye and some of the other clinical examples. Cataracts. Cataracts are sort of the clouding of the eye's natural lens and is most common cause of loss of vision in people over 40. Although, just a quick note to you, there are babies who are even born with cataracts. It can happen at birth as well, but it's most common loss of vision in people over 40 and the most frequent cause of blindness. So there's different types again, and that the talking about that extensively is beyond the scope of this course. But dietary intake of vitamin E, lutein, and omega-3 may help reduce that risk. And in terms of treatment, surgery is the most common approach. And in surgery, what they do is a removal of the clouded lens, and then they often replace it with a clear plastic intraocular lens. Another common thing that might happen is a lens transplant. Actual donation of lenses at death is not an uncommon organ donation that can result in the option of a lens transplant in somebody who might need that. And you've probably heard of this clinical application as well, a retinal detachment. What happens in a retina detachment is that the retina pulls away from the layer of blood vessels that provide oxygen and nourishment. If it's not resolved, it can lead to a permanent vision loss. And the signs and symptoms that somebody might experience related to that is sudden floaters, flashes, reduced vision. Risk factors are aging again, history of detachment. If they've had a previous detachment, they're more likely to have another one. Previous eye surgeries, such as cataract removal and eye injuries, may make somebody vulnerable to them. And the most common way to manage this again is going to also be surgery. So one of the possibilities for the risk factors here is that it can be a traumatic onset. So, for example, on a football field or on a hockey rink, a real hard hit might result in a retinal detachment. Papilledema is another clinical application, and that is increased pressure in or around the brain that results in swelling of the optic nerve inside the eye. So the optic disc swells, and that can cause headache, nausea, and can lead to a loss of vision, as well as maybe some complications due to whatever underlying condition is creating that. It can be an emergency, especially if it indicates an underlying condition of increased intracranial pressure. So, for example, somebody with a condition of controlled hydrocephalus. I'm thinking of somebody with potentially myelomeningocele or spina bifida who's got an indwelling shunt in the ventricle. If there's increased intracranial pressure because there's a blockage of the shunt, papilledema is a medical emergency. Now, sometimes the increased pressure is something we say is idiopathic, basically meaning we don't know what's causing it. And in that case, it may be treated either with diuretics or with surgery. So just some visual images of what that looks like over the next series of slides. So this picture, they're looking back at where the optic disc is, and then showing you a picture of what the normal optic disc is. Okay, and then what a choked disc might look like. This is just for your information. PTs do not commonly check the optic disc on the patients that we serve. So now let's think about some problems with the focal points and look at some of the clinical implications of that. If somebody is nearsighted, called myopia, that means that the visual image focuses in front of the retina. Okay, whereas farsighted, hyperopia, the visual image is behind the retina. And astigmatism means that there's a problem with the curvature of the eye, cornea, and remember that also controls the shape, so that the focal point then ends up being distorted. Presbyopia, which is the aging eye, is not a disease really, but it's a symptom of aging in which the individual has difficulty seeing up close, mostly because the lens has become less flexible, so it doesn't adapt to different circumstances, and so the person can't adapt to something that's held close to them because the lens has become less flexible. And the typical onset of presbyopia is around 40 to 50 years of age. You hear from those individuals that their arms have become too short when they're holding something that they're trying to focus on because seeing up close becomes more problematic. So all of the above can be treated either with glasses that correct whatever the image dysfunction is and correct the error. And sometimes surgery can also be used to alter the shape of the eye. And so here's just a picture of what we were talking about. Okay, so you see that nearsightedness, the visual image is focused in front of the eye, so by the time it gets to the retina, it's unfocused. Or in farsightedness, visual image is focused behind the retina, so again, what the retina sees, again, is unfocused. And then the astigmatism, you can see that the whole image is distorted because the shape is incorrect. Now let's shift gears here a little bit and look at what the visual pathway is. here. Here's another picture of the visual pathways. Okay, drawn as a simple pathway from the previous slide, but actually you can see the optic radiations in more detail on this picture. And again, that's going to be the lateral geniculate nucleus for orientation of where you are in this picture. Okay, and though optic radiations happen in the parietal lobe as well as in the temporal lobe. And again, those are called the ones that are mostly injured, which we'll get to in a bit, are called the Meyer's loop. And this is just a wet specimen showing you the same areas, but on a picture that is of the actual brain, so you can locate it here. And here again, this is going to be just another view of it. And what I want you to pay attention to here is where the primary visual cortex is located, around an area that we call the calcarine sulcus, and you have what's called the upper and the lower bank, and that's the primary visual cortex that where you are actually making sense of the visual image that was first projected onto your retina, and then headed back towards your occipital lobe, specifically the calcarine sulcus and the upper and lower bank. So visual field information and projections. You're going to have a slide of this in just a moment. I'm going to describe it, and then we'll get to the slide that actually depicts it for you. So visual information from the right visual field, okay, think of that, right visual field, activates neurons in the left half of the retina of both eyes. Okay, so, and then from the left visual field, that would make sense then that it activates neurons in the right half of the retina of both eyes. We're going to have a visual on this in just a moment, so bear with me. And then axons from the temporal half of the retina project ipsilateral to the lateral geniculate body, and from the nasal half of the retina cross the midline at the optic chiasm to project to the contralateral geniculate body. I know that's a lot of confusing words. Let's look at the picture that depicts that. So you see that the nasal field on the right side is green, and the temporal field on the left side is green, and then contralaterally on the other colors. So let's just follow this this slide as we keep adding pieces in. So the left eye visual field and the right eye visual field, okay, and if you follow this, look at the visual field for the left eye, for example. Okay, can you see that the left temporal visual field projects to the left nasal retina, and the right, and on the left side again, the nasal field is projected to the temporal retina, and then vice versa for the right eye. And if you can follow me further, you can see I'm sorry, excuse me, you can see how it gets colored in on the eyes themselves. Okay, so you see that left half of the visual field. Okay, the left half of the visual field then goes to the nasal retina on the left eye and to the temporal retina of the right eye. Okay, whereas the right half of the visual field goes to the temporal retina of the left eye and to the nasal retina of the right eye. Okay, so then just again now picturing it on the projections themselves, you can follow those colors as they project to the cortex. Okay. Okay, and so a visual cut can occur such that you have either a complete lesion of the retina or optic nerve, with what's called anopia, or a total loss of vision in the ipsilateral eye. And just a brief note here that some folks use anopsia and some folks uses anopia. So for example, Lundy Ekman uses anopia to describe the visual cuts, and Dr. Bonslide uses the word anopsia. It's really the same thing. Let's define something here. Homonymous or homonymous hemianopia is the loss of visual information from the same visual field in both eyes, so the left side of both eyes or the right side of both eyes. Whereas a bitemporal hemianopia is the loss of visual information from both temporal fields, also called heteronomous hemianopia. Okay, so it's bitemporal, which that's kind of self-explanatory, isn't it? The temporal field in both eyes, or heteronomous hemianopia, whereas the loss of visual information from both the from the same visual field in both eyes is homonymous hemianopia. So let's just give you some examples here before you're going to explore this a little bit on your own for just a bit. So look at this picture of a complete loss of vision in one eye because the optic nerve is significantly damaged on that one eye. Okay, what do you expect to see in that case? Okay, you're going to expect to see the complete loss of vision in that particular eye, right? That makes sense to you. What about a damage though to the optic tract? What about a damage there? So number 2 there, what do you expect to see under those conditions? Right? So if you trace that out, what you end up expecting to see is what we call the homonymous hemianopia. Okay, and again, if you trace that, it should make sense to you why you might see that. Okay, so that you're basically, in this case, missing the left field of vision for both eyes. So the same side, and this is probably one of the more common injuries that you might expect to see. Okay, now here's another damage to the optic radiation. Okay, does it make sense to you that you're going to sort of see the same type of injury that we just described with the optic tract, because it's the same connections when you're looking at the radiation over here. Okay, so you're going to see contralateral homonymous hemianopsia. Okay, but what about the optic chiasm? The optic chiasm can be damaged if there's, for example, a pituitary tumor. What's going to happen there is that the temporal field of vision of both eyes gets damaged. And again, if you trace the colors through, you'll see how that happens to be, right? That the temporal field of vision in each eye is going to be damaged. But that essentially what's projected onto the nasal retina. And then the last one here, what about the Myers loop, optic radiations in the temporal lobe? Okay, and once again, if you're able to track it, what you're going to end up seeing is what we call a homonymous or homonymous superior quadrantenopsia. So that means that what we're going to be missing is a quarter of the field of vision. So if you divide it into quadrants, what's going to end up happening is that you're missing a quadrant of the vision. Now, in order to actually track that, it's much more complicated than we're diagramming. But just to basically summarize, it's the superior quadrant that is the most likely to be injured under these conditions. Okay, and so that one is going to be less easy to track, less easy than, say, the homonymous or the heteronymous hemianopsia. And so you just are going to have to sort of go with it that it's the superior quadrant that's going to be injured on when the Myers loop is injured. Okay, and so here's just some visual images of what that might look like. Okay, so to the track or to those radiations there, what you're going to end up seeing is the homonymous hemianopsia. Okay, and to that Myers loop that's lesioned there, you see this superior quadrant, and therefore homonymous superior quadrantanopsia. Homonymous because it's in the same visual field for each eye. Okay, that's also sometimes called pie in the sky. Okay, so at this point, we're going to break, and I want you to insert the lesion and draw in the visual deficit on this slide. Also, what you can do is there was that PDF picture that was uploaded, and if you've not done so yet, complete the follow that picture, because I think it does a very nice job of connecting the lesions to the visual deficits, or complete the diagrams on the previous slide. And then once you've done that, then go ahead and begin part 2 of the recording.